So two wonderful talks on covering a large gamut of interventions in terms of structural heart. We've seen mitra clips, tricuspid clips, and now we've heard a lot of details about TAVI and how, hopefully, how the future will unfold. Yes, sir.
The transcatheter TAVI for patients with rheumatic heart disease. Nowadays, patients with prosthetic mitral valve who develop later on aortic stenosis, and TAVI is being done for that. What is your experience?
So I think it is a very important question. You have to always consider the age is the most crucial factor. If anyone who is a rheumatic heart disease underwent a mitral valve replacement already and now they have come up with a severe aortic stenosis, if they are very young,
Yeah.
and depending on what kind of mitral valve prosthesis has been used, that also we have to take into consideration. If anyone underwent a mitral valve replacement with a metallic valve,
Yeah.
and he is anyways on anticoagulation, and if he is young, less than 60 years, and if he needs an aortic valve replacement, I still feel a metallic aortic valve will be a one-stage procedure for him, and he will not require further any intervention. Because if you consider a tower and if you consider any bioprosthetic valve, again this patient will require, because the durability of these tissues are 10 years as what maximum has been seen so far as the data says. So if any patient is already on anticoagulation with metallic valve, I think the one-stop solution for him will be a metallic valve replacement at the aortic level. If, on the contrary, if the patient is elderly, like 55, 60, underwent a mitral valve replacement with a bioprosthetic valve, if they are coming up with a severe aortic stenosis, then the scenario is completely different. You have to consider all other factors, the second surgery, all other comorbidities, how fit they are for the second surgery or second sternotomy. These all factors plays a significant role. If there are multiple comorbidities and they are high risk for second surgery, still tower can be a better option. But if it is a metallic valve, anticoagulation, in young patient, one-stop solution will be a metallic valve.
You want to avoid second open heart surgery as much as possible.
This is and now individualistic approach. If the patient don't want second open heart surgery, then obviously the only interventional option what we can offer them will be a tower. That is what available as of now.
Sai, look at two different types of mitral regurgitations. One is the functional and the other one is structural. Now, in your experience between the two, after the mitra clip, which has got a better prognosis, longevity, and ease of doing the procedure, between the two, are they totally two different birds?
So that's a deadly question. I'm going to try and answer it as honestly as I can. Initially, the functional mitral regurgitations were what we were given because all the degeneratives, gold standard was surgery. If you had a flail, if you have normal LV, the surgeon will reflexively gobble it up. But what started happening is very few surgeons were able to do good repairs. Now a lot of surgeons are doing great repairs. So functional mitral regurgitation, ease of use, the procedure is easy because the volumes are all big. If you know what you're doing, you will get away with it clean. But the post-procedure management is tricky. And if you choose your patient well, they just chug along without any problem. So coming to the FMR group, the treatment we have, because they don't have a surgical option. So the treatment we have is, if the MR is significant, is mitral clip or mitral non-surgical repair with whatever device. And if you get the patient off table, what is important is you need to get good leaflet insertion, you need to look at pulmonary vein flow reversal, you need to make sure your gradient on table, see they will tell you 5, 6 gradient we accept. But when I've accepted 6 gradient and the guy wakes up, next day morning it's 8 and I've made him more miserable than he was with mitral regurgitation. So my cutoff is 4, 5 maximum, and on table before I get off anesthesia, I will make my anesthetist mimic waking. He will raise blood pressure, he will reduce blood pressure, he will rush phenylephrine. And once he says, sir, with all the tachycardia, with everything, this is the maximum you're getting, only then will I release the clip. If it is above 5 the gradient. So FMRs, surgical options are limited. transcatheter option is the best we can do. We have COAPT, robust data. We have EXPAND, robust data. We have the Mitra Bridge study, where they looked at 23 different studies across Europe and America and saw that 24% of patients who were waiting for heart failure, heart transplants, who underwent a MitraClip. Now these are the morbidly ill patients. These are the FR group, not the COAPT group. They went off the transplant list. 1 in 4 went off the transplant list. So we know it works. Operators are becoming better. The less MR you leave the patient with, the better they do. So this is that. Degeneratives, by and large, tend to do better when you see them clinically. Because the FMRs will limp. By about 6 months, they will start getting better and get to a stable state. The guy who was in pulmonary edema, who couldn't climb 1 flight of stairs, will say, "Doc, I want to go to the gym, I want to play tennis." If you get a clean A2P2 prolapse and you put a clip bang in the center, the ease is as easy as the functional. And if you get not only should you reduce MR, you should anatomically contain the entire flail segment. When you scan the valve laterally and medially, there should be no residual flail segment left. That is one. The second thing is, you should be confident enough to take a second clip, even when you have excellent MR reduction, excellent leaflet insertion, but when you look at the mobility, these flails tend to pull upward with each beat. You should be confident enough to put a second clip to stabilize the first clip and put it close enough. And when you start doing this, my SLDs disappeared. Patients did beautifully. So I think, to summarize, the easy cases to do are the functionals with the A2P2. The challenging cases to do are as you go commissural and the acute cardiogenic shocks. The central aid, because commissural you have a high chance of getting stuck in the cording. So the central, the ones that really make you feel good are when you see the degenerative with prolapse, when you put a clip, he comes back, the valve looks beautiful, endothelialization has happened, he's playing 2 hours of tennis. So I don't know.
When you see a
Dr. Satish.
degenerative mitral regurgitation due to, say, prolapsed mitral valve, myxomatous mitral valve degeneration, now what is your cutoff point that this patient should undergo a mitra clip? We see millions of them moving around in your hospital, in our OPDs, in our clinics. What is your cutoff point? Is it the degree of mitral regurgitation and ejection fraction, left ventricular end diastolic or in systolic volume? What are your cutoff points, Hemod?
The minute the MR becomes severe, then I put them on my radar and they have to come once in 6 months. The minute the LA starts enlarging, or the minute the pulmonary vein flow starts reversing, or if they become symptomatic, whichever of these 3 secondary criteria become positive, I consider them for treatment. But if I just see severe MR, no significant drop in LV volumes, no drop in LA volumes, pulmonary flow reversal is okay, blunted, it will be blunted, but okay. Symptoms are not that much because there is a group of patients who are asymptomatic. Echo shows severe MR. I don't do anything to them unless they start showing symptoms or their PA pressure starts going up or the LA size starts increasing and they become symptomatic. What was the second part of the question, sir?
Ejection fraction, do you look at the end systolic volume?
I don't, sir. Usually before that the LA will start increasing, but yes, if the LV starts failing, immediately we intervene.
Satish, one question. I think you have MR and TR together. Many of the people will have. And 50% of the TR get corrected when you keep the mitral correction.
About 35%.
75. What are the patients do you expect that will not get corrected? Any criteria for that? Because we require tricuspid intervention in this patient. Probably only a mitral will suffice, or with this will require. How is there any criteria for that?
Sir, it's a very tricky question because when I see severe MR, severe TR, and PA pressures, if they are subsystemic, see if the septum is bulging towards the left, I won't touch the patient, he'll die on table. But if I see subsystemic PA pressures, I do a cardiac cath, and then I feel that predominantly there is no pulmonary component to that right-sided rise in PA pressure. Usually, even if the TR doesn't disappear, it gets better. 60 PA pressure becomes 40. Torrential TR becomes
Slightly
less
better.
severe. In a clean 30%, it almost disappears. But when they come to you sick with the lungs wet Even with the CT, it's very difficult to tell which will do better, which will do worse.
Not.
I don't know.
Because TR interventions are quite
Very-
complicated and more expensive also. That
Actually, the
And-
decision making is the most important.
Yeah.
So I think the last thing that I will ask you to discuss about is, you've shown some very brave cases, and we should not have a take-home message that every MR should be fixed. Where would you choose an MR versus going down the treatment pathway of LVAD versus heart transplant?
I'm going to answer that question with a controversial line. Every severe MR should be addressed. It should be fixed. Now, if you look at a country like India, it's a self-paying market. How much does your LVAD cost? If you put a patient on LVAD, it's a drastic change to their quality of life. It's a 1 crore expense, 60 to 70 lakh expense. And while I truly believe that there are a group of patients who I will not clip, like the Mitra FR group, 9 centimeter LV, hardly any mobility, then that patient should go on LVAD. But I believe when you see patients like that, the immediate goal that should come to your mind is that if they are transplant eligible, they should be transplanted. So whatever you want to do to bridge to transplant them, you can do. Now, if you feel the MitraClip won't work at all, LVAD to bridge to transplant is okay. But ultimately, the goal for them would be transplant. With the growth of transplant programs and the success of transplant programs here.
I think, Sai, I have one important question. I think we have seen a lot of exciting cases, but all these patient came with a decompensation, emergency room, and everything. I think just wanted to ask, what is your strategy? Because there is a lot of advancement has happened in the medical treatment currently. And what we have seen, majority of this severe MR has been put on optimal medical management. Majority of them convert into a moderate to a mild, and we can buy a good amount of time. So what is your strategy, and can we optimize them when they come with decompensated phase and then assess and then take it?
Anmol, that is the $1 million question. When I started doing MitraClip 6 years back, I would see 10 patients for MitraClip, I would clip 8. Now I see 20 patients for MitraClip, I clip 3. Because the heart failure team has become so good, by the time he comes in, they start ANI, they start all the new tablets, they dry him up like a prune. 2 out of 3 severe MRs has moderate to mild MR by the time they are done. So the biggest culprit for my dwindling numbers in MitraClip is my heart failure team, Dr. Abraham Oman. Please, if you meet him, tell him I said this.
It's wonderful. Thank you everyone for a lovely session.
Okay. Thank you, respected chairpersons, for a lovely session and speakers. So now from 11:10 to 11:25, we have a tea break. Please be here at 11:25 sharp. We'll be starting on time. Yeah, be here at 24. Yes, correct.